Good afternoon, everybody, and welcome to this AbbVie-sponsored afternoon on Parkinson's learning. We're going to be looking during this webinar at the 4 stages of Parkinson's disease. The first Academy webinar will be looking at the first 2 stages, and the latter AbbVie promotional satellite webinar will be looking at the latter 2 stages. So without any further ado, huge thank you to AbbVie for sponsoring this learning for us. And up first, we have Annette Hand, Associate Professor of Complex Long-Term Conditions Management at Northumbria University, to kick off this afternoon's session. So over to you, Annette.
Thank you so much for inviting me to come and present this afternoon. It's lovely to be here. What I'm going to talk about this afternoon are the early stages of Parkinson's, and that's diagnosis and maintenance. Now, I've only got about 15-20 minutes, so I can't go into huge depth or detail about those processes or about diagnosis or what we do within that. But what I wanted to cover really was some of the key messages I think that we need to be aware of as healthcare professionals, but also kind of being mindful of people with Parkinson's and their loved ones about what it means to them at the early stages of Parkinson's. So, those are my disclosures. So what do we mean by diagnosis and maintenance in Parkinson's? I think lots of us know about staging with Parkinson's with research and Hoehn-Yahr, but diagnosis, maintenance, complex and palliative are very much English staging in Parkinson's. And they were first termed really by Doug McMahon and Sue Thomas back in the late 1990s, where they came up with this staging really to help us as healthcare professionals in clinical practice understand the different stages that people might go through with Parkinson's. So they talked about diagnosis early being when you first recognize it's kind of signs and symptoms of Parkinson's. But at this stage, the diagnosis isn't really established or accepted. And then when you move into maintenance, when you've got that early diagnosis is established then clinically, but also you've got people who can understand and be reconciled with that diagnosis too, because that can take some time and it doesn't happen immediately. In maintenance stage, people are either on no drugs, or they might be on a single drug or 4 or less doses per day, or they might be on 2 drugs, but stable with medication for about 3 months or more. And at this point, Sue said that there was an absence of postural instability. In the early stages, when this first came out, palliative care was very much kind of at the end of the stage in Parkinson's. But a few years after they first published this, then they changed that to realize that palliative care actually flows through from the very diagnosis. Because we know with Parkinson's, we can't cure it. And many of the symptoms are symptom control and symptom management. And that often can take a palliative approach from the very beginning. So that's not to say this is life-threatening or conditioning at the very beginning, but it's also to say that, some of these things do need a palliative approach from the very beginning. So diagnosis. We all know from the NICE guidelines were published again or looked at again in 2017. And what we're asking for is anybody suspected with Parkinson's with resting tremor, stiffness, slowness, balance problems, or a gait disorder could possibly have Parkinson's. And the most important thing is we're also asking GPs or people who are going to refer to us to do that untreated, because having treatment is one of our diagnostic criteria. It's really important for us. When I first started in Parkinson's, a number of GPs would put people on treatment, and it made it really difficult to understand how to respond. But it's very rare these days that we do see people coming through to us already on medication. And again, it's trying to do that as quickly as possible, because often these people have taken some time to develop these symptoms in the first place. Another really important part is the review of the diagnosis. So we know that diagnosis can take months, if not several years, to kind of get to that confirmation of a Parkinson's. But we also understand that actually with Parkinson's, we need to monitor that and follow that over a course of time to see how people respond, see if they change, if there are any red flags there, because that might lead us on to different diagnoses, such as typical Parkinson's features. So NICE guidelines recommend that we should be seeing people every 6 to 12 months at least to help us with that whole diagnostic process. Many of us are probably used to using the UK Brain Bank criteria that came out a number of years back, and that's very well established now in terms of a clinical diagnostic process. I really quite like the MDS clinical diagnostic criteria, though, that came out a few years ago, and this was taken from Baz Bloom's paper that was just published in the Lancet last month. And if you haven't read the paper yet, it's a really lovely overview on Parkinson's. But the whole idea about the clinical diagnostic process is that we have suspicion of Parkinson's, and at that point we go through step 1. So does an individual have those cardinal features of resting tremor, stiffness and slowness? If they do, then they're likely to have a Parkinson's syndrome. If they don't, then it's a lookalike. We then go on to step 2. Okay, then so is it Parkinson's or is it another cause of Parkinson's syndrome? So in step 3A, we think about sporadic or genetic. Now we know that only 5 to 10% of people will have a genetic form of Parkinson's. But again, it's really important to establish that in terms of, diagnostic criteria, but also supporting individuals and their families along with that. So again, there's criteria for when we might do genetic testing. But we know for the majority of people, particularly older, there'll be sporadic Parkinson's, and often they could have had symptoms or signs going on for many years. And actually, we know now that prodromal features of Parkinson's can be anywhere up to several decades before the first clinical symptoms of Parkinson's. And then again, we go on to next step, step 3B, because it's only after time and seeing how people progress and how symptoms change and alter that we can be more confident in our diagnosis of Parkinson's, or actually whether somebody's developing atypical Parkinsonism, such as multiple system atrophy, progressive nuclear palsy, cortical basal degeneration, or dementia of Lewy bodies. And then we've got our others, and that's our neuroleptics, our vascular Parkinsonism, our carbon monoxide intoxication, our MPTP, or encephalitis lethargica. I do wonder whether in a few years' time we'll actually be adding COVID-19 to that, and I'll comment on that in a little bit of time. So for me, I think we need to be using a diagnostic clinical criteria to help us with our diagnostic process for people with Parkinson's. I think it's really important that we kind of understand that, and we use that, and we show this to our patients as well, so they can see where we're coming from and how it can sometimes take time in order to be confident with the diagnosis that we come up with. So at the minute, we all know that Parkinson's is very much a clinical diagnostic criteria. There aren't any real tests or scans out there we can use to prove the diagnosis. Some of us might be using DAT scans to help us with the differential diagnosis, or MRI scans, or even blood results. But again, it's still very much a clinical diagnosis at the current time. The criteria that I showed you before is very much looking at motor symptoms of Parkinson's and not the non-motor. And we all know now there are loads of prodromal symptoms, including restless leg disorder, REM sleep disorder, problems with sense of smell, sense of taste, and constipation that can often happen a lot longer before they get those first motor symptoms. And we're looking at how we can incorporate those into our diagnostic criteria, but still be confident in the diagnosis of Parkinson's. I've been really lucky in the Northeast to be involved in 2 studies, though, looking at other ways we might be able to diagnose Parkinson's more quickly in the future. The first study I want to talk about is a metabolite study. And you might have all heard of a lady called Joy Milne, who's a super smeller. Now, she was an ex-nurse who noticed a changed smell of her husband and felt that his smell was different from before he was diagnosed with Parkinson's. She happened to mention this to some researchers, and over the last few years, there's been a number of studies ongoing looking at whether we can actually detect Parkinson's from a change from their smell. So we've been involved in what we call the metabolite study. We've been taking skin swabs, and they've just published a paper earlier on this year that's really promising to help us going forward to actually might be helpful in this kind of diagnostic process. So the next stage will be a larger scale study to look at how sensitive and valid this is. So again, watch out in the future that this may be a form of diagnostic tool for us. I've also been involved with a company who've developed a really clever pen who can detect different types of tremor and bradykinesia and rigidity in movements and writing on a special tablet. So again, this can help us with differential diagnosis particularly, and just trying to speed up the whole process, because we all know how distressing it can be for individuals when we're taking some time over this process itself. But regardless, as I said beforehand, we also might find that COVID-19 is linked to Parkinson's. So there's been a couple of papers published within this, and there have been 3 case reports being published of relatively young people who had COVID-19 who developed Parkinson's, either by itself or with other symptoms, only within 2 to 5 weeks of contracting the disease. And the quote from Dr. Brendan at the bottom here: "These cases of acute Parkinson's in patients with COVID-19 are truly remarkable. They occurred in relatively young people, much younger than the average age of developing Parkinson's, and none had a family history or early signs of a Parkinson's prodrome." This is quite a stunning observation. I think many of us have looked into the kind of history of Parkinson's over the years. We'll know the Spanish flu and encephalitis lethargica and the Great Sleeping Sickness and the impact that has had on Parkinson's and Parkinsonian syndromes. But I think it's also interesting to think about COVID-19 with that change of sense of smell and sense of taste, what we know is a prodromal sign of Parkinson's. So I think it's one to be aware of going forward in the future. And certainly if we're looking at people being diagnosed now, we might need to be asking them, have you had COVID-19 or had symptoms of COVID-19 going forward, to kind of understand this a bit further. But potentially we're looking at more numbers coming through as the years and months go forward. I think for me, though, having done this now for some time, when you diagnose somebody with Parkinson's, it really does affect everybody differently. And again, you never know how somebody will respond given those words, this looks like probable Parkinson's. For some people, it's a real relief to have that, to finally understand the symptoms they've been going on for some years, about what it's all about and trying to join them together like a big jigsaw puzzle. But for some people, though, they're really worried about the future, what it means to them, not wanting to be a burden on their friends and family around them, and wondering they'll be disabled quite rapidly. Other people feel really quite overwhelmed by it, or some people really feel shocked and hadn't really expected that diagnosis in the first place. So certainly as a clinician, it's really important to be sensitive in your telling of the diagnosis and to make sure that you respond to the individual and how they respond to those words that you're telling them. And for me, in the majority of the time, Parkinson's is a non-life-threatening condition, but it certainly is life-changing. And the date that you give that diagnosis to somebody will be etched into their brain for the rest of their life. And how you tell them that diagnosis and how you talk to them about that and how you support them at the very, very beginning will be with them forever, and how they'll really accept you and kind of interact with your healthcare team. So it's really important, it's a sensitive kind of telling of that diagnosis at the very beginning. For me, it's really about information sharing in those at their early times. And so rather than me saying, okay, this is what Parkinson's is all about, I always ask somebody, what do you know about Parkinson's? What information have you had about it already? For some people, they've done a Google search, and I don't know about you, if you put Parkinson's in, you'll come out with millions of hits that can often be really scary and worrying to an individual. But often people do that because that's the only place they know to go look for information. They might know a famous person. So often we've had Billy Connolly and Michael J. Fox and other people out there that's, they might know with Parkinson's, and that might be their impression of what Parkinson's is or what Parkinson's looks like. They might have looked at Parkinson's UK and had some information from there. They might not know anything about it whatsoever. They might have seen a television program about Parkinson's, or they might have a friend, family member who's also had Parkinson's. But each of these individuals will come from a different perspective. They'll all have different information about what they think Parkinson's is or what it isn't. They might also have misconceptions. So it's really important we understand what they know about it first of all, to make sure we get the right accurate information for them. We know from Parkinson's Excellence Network as well, from the audit results that we carry out every couple of years, that this is still an area that we need to improve as clinicians. So in the 2017 audit, when we talk about communication and information sharing, only 61% of people felt they were given enough information at diagnosis. Now, really, that's not great. We should make sure that everybody feels they've got enough information at diagnosis, and that should be both oral information and written information. There's some fantastic resources out there, and certainly I always signpost people through to the Parkinson's UK Excellence Network and information report services. So we have information packs that's out there for people. I'm also really lucky to be involved with the Parkinson's Connect project, and that's connecting people from the very beginning of their journey with Parkinson's and their loved ones to make sure they get the right information at the right time in the right format as well. Because some people don't like reading books, they like to go to videos or podcasts or looking at different kind of webinars to help support them within that. And some fantastic resources out there now to really support individuals. And even when we've been doing work from a distance and having to do virtual consultations, there's lots of things you can send patients to have a look at virtually, or send them links online to look. It's not always on paper versions that we need to think about these days. And again, really importantly, we need to make sure we're supporting family and friends at that very diagnostic point as well. Because often those people have seen how that loved one has changed or altered over time. They'll have seen symptoms developing. Sometimes it might be even troublesome symptoms. But thinking about how Parkinson's may progress and how it changed going over time, it's really important we engage family and friend members to think about how can we support you supporting an individual with Parkinson's. Because we know further down the line, again, they might be very important care partners and informal carers. So again, it's to make sure that they have the information they need. And that's often very different to the person with Parkinson's. They might have different questions or different worries of their own that we need to make sure we address. We need to make sure we have a participatory health model and a team approach from the very beginning. And what's all that about? It's about making sure it's patient engagement, shared decision making, and the patients are very sensitive within that. As healthcare professionals, we'll probably see that person with Parkinson's maybe once or twice a year if we're lucky. And again, depending on how long your consultation is, it may be only half an hour, whereas a person living with that condition has got to be with that 24/7. So we really need to make sure we're meeting their needs, make sure we can help them with their self-management, understanding the condition that they've got, and helping to engage in with activities that really support them, particularly from the early days onwards. And that's often about lifestyle changes and support, and that could be very much regarding exercise and diet and healthy living activities. That's all going to make sure that their Parkinson's progresses as slowly as it possibly, with the least medications possible. Harnessing the power of physiotherapy is really important, particularly from that early stage. And again, we know from NICE guidelines, it says consider referring people through in the early stages of Parkinson's for physiotherapy with experience, for assessment, education and advice. But even if people don't want to be referred through to physiotherapists, there's loads of evidence now to suggest actually, exercise is neuroprotective. I did a lovely webinar on World Parkinson's Day. We had Baz Bloom there who talked about these popping neurons that are going off, making new connections as people even walking, to really kind of promote the form of exercise. And even that was walking. It doesn't have to be too vigorous, but actually trying to keep people as active as you possibly can do. And there's loads of evidence if you look out these days. So even telling people that, even showing that there's a load of evidence out there, so signposting to kind of the research that's out there to show that this, because some people haven't been very active. And again, it's trying to promote and encourage people to be mobile and active and do activities. And again, sometimes it's difficult because somebody says, okay, then what should I be doing in the early stages? What kind of activities will help me with my progression of Parkinson's? And the Parkinson's, again, the Excellence Network have done a lovely framework with some examples that people can do from the very early stages. So that could be anything from cycling or jogging and running and swimming, home DVTs and exercises, and particularly it's been really helpful over the last 12 or so months with the lockdown. Lots of YouTube videos out there that they've got from various different sources to help people. So even if they aren't involved in groups or activity and exercise or can't get to the gym, there are other ways they can be active. But again, it's supporting people from all stages with their Parkinson's, but particularly trying to build that in the very beginning and trying to build into their day-to-day routines they do on a regular basis is really helpful. Also, we may need to make sure we're considering referring people through for things like occupational therapy, particularly for things like apathy or for sleep problems. Often these things have a real massive impact on somebody's quality of life early stages of the condition. So make sure they're properly supported with those activities. Some people early on have communication issues. So again, thinking about speech and language therapy, and also coming to terms with diagnosis like Parkinson's can be very, very difficult for some people. So thinking about psychological therapies, input and support. And again, there's lots of the IAP services around the country that can easily self-refer to and refer people off to rather than having to go via GPs. But all these kind of therapy supports are really vital from the very beginning if people need them, and they're out there and they're designed for people early stages of Parkinson's. And along with that, we've got the self-management. So as I said before, it's really important that we support people to be as active as they can do, to understand the condition that they've got, to understand how things might change or alter over time, things that need to look out for. And I know many of us service have our own newly diagnosed groups with people with Parkinson's that we bring people together. We have a whole multi-professional aspect to that. But there's also some national work that's going on. So if you don't have these early kind of group sessions for people with Parkinson's, then please go and have a look for support within that. They are really valuable to help understand Parkinson's at the very beginning, get rid of those misconceptions, but also make sure we've got healthy lifestyles going forward. So they're really helpful to link into. To treat or not to treat, and that is the question. This is often what I get asked about when somebody gets diagnosed. Now we know again with the NICE guidelines of 2017, it talks about, so do motor symptoms impact on a patient's quality of life? If they do now, our kind of choice is offering levodopa, and that's kind of one of the first things we know we should be doing for them. But again, if they don't want to go for levodopa, we can go for the other options. If the motor symptoms don't impact on quality of life, well, then we can offer any of the choices we've got available to us. And again, that should be only after careful consideration and discussion with patients about what it is they want, what they're after, and how they want to take the medication. Now, we know these guidelines have been developed very much through from the PD Med trial that came through, and there's lots of information and advice out there. Certainly, we know from the recent LEAP study of 2019 that there is no benefit in delaying levodopa. At one point, lots of people felt that the longer they put it off, the better in terms of trying to reduce the risk of developing motor complications or dyskinesia. And certainly the LEAP study shows that that does not happen. So it's really important that you know, if people do have motor symptoms, then levodopa is going to be the one that's going to really improve symptoms, improve quality of life without promoting or hastening up those non-motor fluctuations or the dyskinesia in the first place. But again, it's very much about choice and options. One of the most important things I think for me is about expectations. So people will often say, you know, you talk about medication and what it will do and what it won't do, because we know that with Parkinson's treatment, it might help some of those cardinal features, but it often doesn't help with those non-motor features that people talk about. So it's really important we think about, okay, then what is it that you want from the medication? How do you want this medication to benefit you? What symptoms in particular do you want it to help with? You know, people are tremor dominant, you know, I often explain that, you know, many of the medications have little impact on tremor. It's very then difficult to kind of determine whether the medication works or not if you're just going to base it against tremor alone. It's thinking about all the other symptoms that they might have and thinking, okay, then what will the medication have an impact on and what it won't? So having those conversations with those individuals at the very beginning, but also explaining how the medication works and how long it will take to work is really important. Often we get multiple phone calls from our helpline saying, I've been on this for medication for a little bit and it's not working. Well, actually, it wouldn't have worked, you know, we'll not know for several weeks yet. It makes a difference. So it's about having those discussions with somebody and really supporting them and counselling through drug management. And again, highlighting the mystery of medications are really important too. So again, from the NICE guidelines, it's got, when starting treatment for people with Parkinson's, we need to make sure, particularly impulse control disorder, excessive daytime sleepiness and psychotic symptoms are all discussed and are all kind of mentioned. And we also need to make sure we give them oral and written information about these symptoms as well, so that they've got that and document that. And again, I'll always make sure I put this into my letter at the end of the consultation so that somebody's already got that written confirmation of that discussion I've had with them, they can go back over with if they needed to. And not now is okay. Because some people say, do I have to go on treatment now? Well, actually, if the symptoms aren't impacting on your quality of life or your functionability, it's okay not to start treatment now. There is no rush or panic because we know that there's no firm evidence that any of the medication we've got are neuroprotective or they don't slow the disease course down, and they certainly can't reverse it. And I certainly wouldn't want to start medication if people are an inpatient, because often then they're unwell, they've got other symptoms ongoing, and it's very difficult then to determine the impact of medication and the benefit they might receive from that. Again, Friday afternoons and evenings, I do a clinic on a Friday at noon after in Berwick. And if I start any medication from that clinic, I'll say, don't start over the weekend, start on Monday. Just because I would often hate, if anybody had any problems or, you know, any other questions, that if they do it over the weekend, then there's very few people around to be able to support those individuals. And again, if people are going off on holiday in the near future, you don't want them to be worried about if a new medication is going to have problems or side effects. So again, I often say to people, it's okay to delay it if you want to after your holiday. So not now is okay. But again, it's about having a conversation with the person with Parkinson's and their friends and family to understand what it is that's going on and what they want to do. And of course, managing all the non-motor symptoms. So we know that within Parkinson's, there's over 40 different non-motor symptoms that people can get. And again, we've got rating scales we can do support with these ones. So when somebody comes into clinic and speaks to you about them, it's really important to understand which of these are the most distressing to somebody, which is to cause the most impact on the quality of life, and which ones can we focus upon. And again, this will take a whole multidisciplinary approach. Often medication will have little impact. So it's important that is a team approach along with the self-management strategies that we might be using. So my key messages are a sensitive telling of that diagnosis at the very beginning, because remember, they will have that date ingrained in their brain for the rest of their lives. The date you tell them that and how that's given to them has a massive impact on how they do. Information sharing, not just information given, make sure we understand what they know about the condition before we go into our spiel. Make sure it's participatory health model, but very much including them as that major part of their model of care, and they're leading on that part of their own MDT. Harnessing that team approach and particularly emphasizing the importance of exercise early on, being clear about what will get better and what won't, make sure that not now is okay to start treatment, and managing those motor and non-motor symptoms. And remember, those friends, families and carers are really important to engage very, very early on and through that maintenance stage, because often it's those people who have a major impact on their life as the disease progresses, and there's greater burden on their reliance and their support for that person with Parkinson's. Thank you.
Thank you very much, Annette. That was a really comprehensive discussion in a very short time about diagnosis and maintenance in Parkinson's, so thank you very much. Now it's my pleasure to hand over to Dr. Conor Maguire, consultant physician in geriatric and general medicine in NHS Lothian, just to add his own comments and take us through the questions and answers. So Connor, over to you.
Thank you very much, Daga, and thank you, Annette, for a really clear run through a very important part for most people with Parkinson's, which is finding out they have the diagnosis and those early few years. Before, and you led us nicely talking about the pre-diagnostic or prodromal features, the diagnostic, starting treatment. But one thing that came out is very important from your talk is about communication. And I think empowering the patient, empowering the person with Parkinson's. Can you tell me about some ways you feel, and I'll share what I feel, we can empower people. A lot of people at the very beginning feel overwhelmed and they go into a shell. And I know as a doctor, I have to say, I'll see you back in 4 or 6 months or whatever. And I think it's a long time. And how do we make that first few months best for people with Parkinson's? How do we empower them more? And how do we communicate better in your mind?
Yeah, it's difficult, isn't it, Connor? So certainly there's an awful lot of information that first, meeting alone. Often I'll spend if I'm lucky, an hour with somebody when they're newly diagnosed, going through all the different bits and pieces. But again, it's given that information that they need at that point. And again, we have access to nurse specialists or a nursing team. So what I will do is I'll book them in with a nurse specialist, quite soon after they've had that initial meeting with myself or with another consultant with that diagnosis, to go through kind of any questions they might have. Because sometimes it's about going away, isn't it, and having a look into information, have a think about it, that they've then suddenly thinking, but what about this? What about that? What do I need to ask about? So it's about having that another one-to-one with somebody on top of that. And again, we have a support line as well. So we say somebody, look, this is our support line too. If you've got any questions or queries, anything I've said that you're not sure about, please contact us. There's no silly daft questions. We're here for anything we can help you with. Again, sharing copy letters to people so they know that there's a discussion. Because again, I think, you'll pick up 2 or 3 points, won't you, from a consultation, but you won't take it all in. So trying to provide a really detailed letter. And again, I write my letter to the patient themselves now and then copy that into the GP. So say, when you came to see me, this is what we discussed, this is what we looked at. And that's really helpful for things like driving, because we know that when we get that potential diagnosis of Parkinson's, they need to make sure they inform the DVLA. It's a legal requirement. So it's making sure you kind of get those key messages in. And again, if it's like medication, you can make sure you've got those key things about potential side effects, like those impulse control disorders, how we spoke about that in the consultation. But it's having multiple methods, I think, Connor, that we can support people. And I think that's why I really like being involved with the Parkinson's Connect project, because it's just another way of supporting people and family and friends members earlier on. And I know I'm really lucky at the minute to be a pilot site for that. That's going to be kind of rolled out later on this year to other sites, then hopefully before it's rolled out more nationally. But I think it is, there are so many people that we see now, and it's thinking about how we can support, lots of different people in lots of different ways, but make sure it's the right way for them.
I know that as a profession, I would say doctors were very paternalistic. I notice I'm not saying the nursing fraternity. And it took us a long time to start considering sending letters or copying letters to patients. And I've been doing it for a number of years. And initially, my fears were people will come back and say, you said this about me, or you said that. I must say the thing I find hardest is trying to get it in layman's language. So we use a lot of terminology, hypomimia, nocturia. So my secretary's used to me going, hypomimia, open brackets, reduced facial expression, close brackets. I haven't quite got on to writing to the patient and copying the GP, but I know a lot of people are doing that. I'm finding it very useful. But I do feel the more information we provide for our patients, the better they come prepared for clinic. And the fewer questions you get asked at future clinics, actually, rather than the more questions. I wanted to ask you briefly about what your thoughts were about that. You talked about some of the prodromal features and restless legs, anxiety, constipation, anosmia. And you talked about joy and the sense of smell. Do you think we're going to get to a stage where we are picking people up based on symptoms? I'll add on to this that if I go back 20 years, I don't think general practitioners were as good as they are nowadays at picking people up. And I think it's because a lot of trainees go through geriatric medical or neurology services when they're training, but there's a lot more education out there. But do you think we're going to get to the stage in the near future where GPs are picking people up, or we're adding in the prodromal features before other features appear?
I think so, Connor, and certainly when we move forward, when we think about neuroprotective agents, it's going to be really important. The sooner we can get in there, the better. I mean, I know over the last few years, we've had a number of people referred through to our service from sleep services, with REM sleep disorder, particularly thinking, actually, could this be a, prodromal feature of Parkinson's disease? And at minute, that's really difficult, isn't it? When you've got somebody referred through to you saying, I don't know, I've been referred through to the Parkinson's clinic. I shout in my sleep, and, I move around a lot. And I know that other health professionals I've got some awareness of some of those prodromal features. And I know things like constipation, and often people have had that for a long time before they get the early symptoms. But I think going forward, I said, it'll be really helpful when we do have those clearer diagnostic processes. So it may well be that we can do that metabolites, skin swab. It might be we can do something else that's going to kind of give us that understanding that this is definitely Parkinson's we're treating and dealing with. But also having those treatments that are neuroprotective. So I think there's a combination of things, but I think we're starting to see it now, Connor. We're starting to see people coming through to us. And I think, people are raising that awareness, particularly like things that smell and taste. And again, with the COVID-19, it's going to be an interesting going forward, because I think it's just becoming more and more on people's radars.
Interestingly, the false positive and his wife are both my patients in the sense of smell. The other thing that makes, I'm a geriatrician, and one of the things that makes it more difficult sometimes for me is, and you talked about the Parkinsonian lookalikes, the depression, pyramidal slowing, and in an older person, it sometimes makes it more difficult to pick up people with the diagnosis. I know I never say to somebody, you don't have Parkinson's. If I don't suspect it clinically, I say, I can't find any Parkinsonian signs at the moment. That's not to say that you may not develop it in the future. Have you any tips from a nursing point of view, and I'll put some from a medical point of view, for picking up when people have comorbidities and maybe the slowing of arthritis, etc., in older age?
No, I mean, it's really tricky, isn't it, when you've got people who are frail who are coming to see you. But I think it's having an awareness of all the potential lookalikes or things that might cloud that kind of clearer judgment, or cloud that clearer diagnostic process, using some of those rating scales, trying to treat some of those symptoms beforehand, trying to treat that anxiety, treat that depression, if you haven't got some of those cardinal features that we're looking for as part of that diagnostic criteria. But very much like you, sometimes it's a case of, there isn't that kind of criteria there yet, but we'll watch and wait and see. And if things change or alter, then get back to, before us hand. But again, I think linking with the family and friends, because often they pick up on those subtle signs and symptoms that the person with the condition might not themselves. So it is trying to have a look, isn't it? And again, it's about those conversations, and it's about, have you noticed slowing in this area? Have you noticed difficulty with that kind of activity? And again, I tend to like using the MDS UPDRS. I know it's mainly used for research, but for me, it's quite handy because some of those questions within that, both non-motor and motor, are really helpful kind of prompts that you might ask somebody about. And again, if you've got that more of a rating scale or an assessment process, and you can always go back to that again and see if there's any subtle changes. Whereas sometimes I think if, one person sees that person like yourself, Connor, and then, I do it the next time round, we might miss some of those subtleties. So actually having some sort of, tool or assessment tool that we can use to kind of help pick up some of those early things are really helpful, I think, because then moving forward, you can see if there've been any change or alterations in symptoms or signs.
Yeah, I think watchful waiting it's if we can do it. I know a lot of us are restricted in the amount of outpatient clinics we can have. I know I had somebody recently who last year I saw and had a degree of what I would say psychomotor retardation, and mood was extremely low, but I also suspected probably was early Parkinson's, and his family were very keen that he start on medication now. And I said, I'd rather get his mood better first. And when his mood improved, his symptoms improved. But no, I've just more recently started him on treatment for Parkinson's. But I think it was the right thing to do, because it would have made it more difficult to make a diagnosis, a true diagnosis. Going on to that, I'd be interested for your thoughts on DAT scan. You didn't mention DAT scan as much when talking about diagnosis. There is a fine line, I think, between doing it on everybody,
yeah,
and doing it on those that you feel you're trying to work out, is it a dystonic tremor, is it a pyramidal, or is it a cerebellar or whatever, or an essential tremor, is there a crossover? Have you any tips for the people looking at this? And I'll give you my tips afterwards.
Again, it's a diagnostic, it's a useful diagnostic tool at times to say for those differentials. Guidelines currently tell us that we can use it, for those differentials, but not within Parkinson's. And I think for me, the worry that I have is if somebody does a DAT scan and it's abnormal, then we say to you, oh yes, it's definitely Parkinson's. And unfortunately, I've seen a number of people then gone on to develop an MSA or a PSP. And for me, there's nothing worse than saying to somebody, actually, no, this isn't straightforward Parkinson's. You've got an atypical Parkinson's that actually is life-threatening and life-shortening. And that's really distressing for somebody. Yes, I do refer for DAT scan if I feel it's appropriate, certainly particularly for those tremors, I must admit. But if I think it's not going to change the kind of clinical course of a condition, then I'm kind of more reluctant to want to do that. There's no point sending somebody for a scan that, again, often people struggle with because it's got to be lying flat for that 40 minutes. And if somebody's kind of like older or, got arthritis or uncomfortable pain, discomfort, then, they're not going to tolerate that, so just make sure that they would be happy doing that in the first place. But if I'm not going to start treatment on somebody because they've got very mild symptoms, and there's no point me necessarily doing a scan at that point, sometimes it's better just to watch and wait and have that bit of time, because I think that's a kind of like far more helpful diagnostic tool sometimes than a DAT scan itself. So it has its place, but it certainly shouldn't be the be all and end all for everybody, because it's not that 100% certain, and there can be other reasons why somebody would have an abnormal DAT scan, and we need to make sure we don't just use that as it's definitely Parkinson's.
I must say, most people I see, if I say, I just want to see how things go, you've spent 45 minutes or whatever with the person, I give them paperwork and I'll say, go, here's some things to read. I'm not 100% sure, but my suspicion is this. I'd like to see you back in a few months' time and review things. I must say 9 out of 10 people say that's perfect. It gives me time to think about it. But they say we'll give them time to think about it as well. We talked about empowering the patient and self-management of participatory health. What about relatives, educating families and carers? Often we direct things towards the person themselves, but a lot of the angst I see is from those around the person with Parkinson's. Are there many resources for helping families? I mean, if they're younger, well, not necessarily younger, but if people are more computer literate, they often do the Google search, and I direct them, for example, to Parkinson's UK, which is a terrific resource. Have you any other thoughts for educating families?
There aren't, yes, Connor. I mean, that's one area that we all, I think, need to develop. That Parkinson's UK have appointed a family, friends and carers lead with Nicole Kirbisher a couple of years ago, because we know that's an area where there's not that much information support. There's a few documents about, my father or my mother has Parkinson's. It's developed, designed and developed for those younger, sons or daughters or family members. And again, we know that, within Parkinson's, there's like looking after somebody with advanced Parkinson's, all are the symptoms. But for me, I don't think we really provide information for somebody at the beginning of the journey and through the transition stages either. One of my special areas in research is looking at carer strain and carer stress and the impact that can have on an individual. So I'm only too aware of the problems that can happen later on down the line. So for me, it's really important we try and engage people much earlier on in the disease process, make sure they're active partners from the very beginning, from the diagnostic. If the person with Parkinson's is happy with that, and explaining why we do that in the beginning, but supporting them along their journey too, because they are very much impacted by the Parkinson's condition itself and the symptoms that people might display. Their quality of life is also going to change, their health and outlook, is also altered. So it's about making sure that we can make sure they're healthy, making sure they're looking after themselves too, and activities. Because I've seen people, care partners not looking after themselves, their own health deteriorating, their own quality of life deteriorating, becoming depressed and anxious themselves. So I think, there is information out there, Connor, but there's not enough. And I'm certainly working at the minute trying to develop more information and doing that along with Parkinson's Connect, and also trying to get a bit more research done as well, because we just don't fully understand how best to support people at various stages about what information is right for them. How can we, make sure, is it support programs that they want? Is it, have we got an educational training program? We've got things on Parkinson's, but we don't have anything to support care partners. So we're trying to look at developing something to support those carers from the very beginning of their journey too.
Sura Al-Bayati has asked, thanks for a nice lecture. Can I ask about the percentage of patients who are known to have essential tremor progress to idiopathic Parkinson's?
I don't know those numbers, Connor, do you?
No, I don't know the numbers. I do know that some people are diagnosed as having essential tremor who actually have an early Parkinsonian tremor. And I know there is obviously a crossover now that is becoming more recognized between essential tremor and idiopathic Parkinson's. I'm not sure the percentage. I do know that if I'm referred to somebody and they have essential tremor, I manage it at essential tremor. I talk to them about essential tremor, and I do say to them, I cannot say that 100% that this is not a Parkinsonian tremor, because a lot of people do come and they hope that's the question they want to know: is this an essential tremor? When we talk about treatment, and you talk about Doug and Sue's phases of treatment, can I ask you about people taking what we call PRN, or occasional extra levodopas? So we talked about people taking it 3 times a day or 4 times a day, but even in the earlier stages, I have somebody who does get that hit. I'm not talking about dysregulation syndrome, but a person who says, yeah, it really helps when I take it at breakfast and at lunch, but then often I'm going out to meet my friends in the afternoon, and I don't want to slow down. And even though I don't have wearing off, I just like to take an extra one. What do you do? What's your advice? I mean, we're talking about self-management. This is self-management.
Yeah, we are. I mean, for me, yes, that early, dose of co-beta dispersible is really helpful, isn't it, to keep people going first thing in the morning. And people have very different days, so some days are better than others, and some people are more active and want a bit of a boost. And I think for me, it's about trying to keep people as the best they can do. I want them to still do those activities. I want them still to enjoy going out with their friends, or going for that walk, or doing that activity. And if that means actually taking dispersible allows them to do that far better, then that's good for them. I think, it's all about that quality, isn't it? And that mental health stimulation too. But I think it's about trying to make sure you kind of monitor that and understand that. So for me, I'd much rather prevent some symptoms happening than having to treat them happening with a dispersible. And I think sometimes we're a bit cautious with our levodopa doses. I know when you look at other papers out there, they lose much larger doses of levodopa, and it might go, but actually, and I think it all depends on the individual. I think, lots of people can probably tolerate a slightly bigger dose or higher dose. And I think if it's beneficial, then I as long as they're not popping, and you're right, they've not got the dopamine dysregulation, then actually what people need to keep them going through the daytime is important for them.
Yeah, and some people I noticed in Michael J. Fox's autobiography many years ago, he wrote about taking an extra one when he was going for screen tests. And I use a phrase in clinic. I say, when people say, oh, they look almost ashamed and say, I took an extra one. And I say, I am a consultant, I'm not a dictator. And a consultant means you consult with me. I'm not going to dictate what you should do. Sura also asks, any experience in using selegiline to treat fatigue as a non-motor symptom, i.e. the use of amphetamine within selegiline?
To be honest with you, I've never seen any great response from selegiline with fatigue. I think fatigue is one of those really difficult things to treat and manage earlier on, and throughout the course of Parkinson's as well. It's one of those non-motor symptoms that really can be very impactful in somebody's quality of life and functional ability. And I think it's probably a combination approach. I must admit, I've had probably more response from the OTs with fatigue. If I'm honest, having a look at some strategies and management activities they can do to support an individual, rather than using selegiline alone.
Yeah, I completely agree. I won't say what I call selegiline, but it's a little sweet that comes in different colors. Apathy is the other thing that's obviously quite difficult. And a quick last question, because our time is about to run out. If they take an extra dose of levodopa as a booster in diagnostic stage, would you advise they take their regular dose after a set interval, like 5 hours later if the usual regime is 5 hourly? I think what I'm saying is a person's not getting wearing off. You get some people that just are afraid they'll wear off in a social situation. If I think somebody is wearing off, I would change either the dose that they're on, consider adding something in, or the frequency. The problem with frequency, they did a wonderful study a number of years ago with medical students, and they gave them tablets to take 3 times a day for a week, and most students had at least 1 tablet left at the end of the week, and they swore they had taken them 3 times a day. I don't know, Annette, if you have anything to add to that before we close.
No, just that we know that with concordance, you know, it's difficult and easily people forget early stages. It often doesn't make a difference if they miss a dose. It's only later on down the line that's obviously more relevant to them. And you're right, I'm the same with you with the dispersibles. It's, you know, take regular medication as per, but that be add-on.
Okay. Thank you very much, Annette. That's
Thank you.
our time up. I'll hand back to Diga.
Brilliant. Thank you, Connor, and thank you, Annette. Very comprehensive 46 minutes there. Brilliant stuff.